patients who was on the control arm received this experimental treatment after they progressed. So there was a crossover, or this treatment was available off study, and a lot of them did receive it after. And then I don't see an overall survival benefits. That could give me an explanation why there is PFS improvement, but there's no OS improvement. And it's also if the PFS was significant, like not just a few weeks, it was like few months. So I will buy in.
Okay. And overall survival, would that definitely convince you?
Yeah, definitely.
Prescribe?
Almost OS is the gold standard.
Okay, I see. And so I would like to ask you about some of the different approaches to combining these agents. So as you may know, in the second-line setting now, NCCN guidelines recommend nivolumab with or without ipilimumab. What did you think of the data that you saw from those agents in the second-line setting or second-line plus setting?
It's really promising. It's promising data for a very deadly disease, now a very effective treatment. So I understand how the NCCN guidelines adapt the recommendation to use it as a second line without like FDA approval or a large phase 3 study. I did use it in my clinic, and I did see good results. It's toxic combination, so it needs somebody who is very well trained or familiar with immunotherapy, especially combination. So it's not like just PD-1 or PD-L1 monotherapy. And it's more toxic than chemotherapy, immunotherapy combination.
I see.
So it's a difficult treatment, and I mean, but it's effective. Some patients are having a lot of mileage with this treatment.
Yeah. So would you prefer to use the monotherapy or the combination for these patients, given the toxicity and the efficacy profile?
I mean, the efficacy profile justify using the combination. I would prefer to use the single agent because it's much easier for me and for the patients. But if we're compromising the efficacy, so I would still, I won't mind using the combination.
Yeah. For the combination, then, would you prefer to have a biomarker such as TMB that could then guide in terms of which patients are more likely to benefit?
Oh yeah, ideally, if we could have the biomarker tests that tell me this patient will not benefit from immunotherapy, this patient they need the combination, this patient will have the same benefit if you use just PD-1 monotherapy, you don't need to use combination. That would be ideal. I don't know if that's gonna see this anytime soon.
Okay, I see. So would you say that having a biomarker would have more importance when you have CTLA-4 in the combination as well, because this combination has higher toxicities and therefore justifies the biomarker use?
Absolutely.
Okay.
If I'm gonna use the combination with like high taxation to the patient, I would be inclined to know if this is the right treatment for him or not. I mean, it would make a lot more sense to do that.
I see. So I want to talk about some of the emerging trials or emerging agents in the first line extensive